We're excited to get the afternoon kicked off here of our seminar. So first we'll have a translational research exemplar called Clinic to Lab to Clinic, and that will be Dr. John Bird, who is here, and I'll have him come up here in just a second. And then we'll go into special issues in rare disease study design so that we can. It's a quasi-presentation / panel, more so a panel than presentation, but you'll see how that is going to operate in just a few minutes, or after Dr. Bird, and that will be an opportunity to ask questions about designing studies for rare disease research and to hear some input from our panel. Then we'll move on to research support that's available via the CCTS, and we will talk a little bit about recruitment and some of the other tools and resources that are available to you as researchers, and that we encourage you to access. And also that includes the T4 panel that we had just had for you. You can do that as well. And then we will finish up the day with an expert panel called Getting Grants Funded, Papers Accepted, and Results Disseminated. And so that will be how we round out the day. So let's get it started so we don't get behind like we did at times. At least we somehow caught up. But in the first half of the day, this is Dr. John Bird, and I'll get his slides going here. Yeah, they did. I just have to figure out which one of these is. There we go. Okay. All right, thanks.
Thanks, Jeff, for inviting me. And so what I hope to do in the next 80 minutes, is that what you said? Okay. Yeah. Say, I think 20 minutes. Talk about a little bit about translational research that our team has had the opportunity to do around a disease called CLL. So let's get started. Another misnomer today. This is a slide about CML. No, that's the right story. So CML we'll tell the story that we're going to tell about translational work starting with CML. It's a leukemia that when I was a fellow, was a disease that in the 70s was identified to have a common translocation, which creates the BCR-ABL gene, or fusion gene, and which drives oncogenesis and a very pathogenic type of leukemia called chronic myeloid leukemia. And as a fellow, this was treated with interferon and cytarabine, chemotherapy, and unless you were transplanted, your survival expectation was 5 years. And the introduction of a targeted drug, Imatinib, that targets this fusion gene, the BCR-ABL, completely changed the landscape of CML. And you see here, this was the survival of CML, and then here we can track the post-Imatinib survival. And so this is really what we want to do in CLL, is to change CLL to a disease that's like CML, where patients can be treated with a pill, take the pill, and not have to go on to transplant, not have to go on to chemotherapy, and live their expected life. And Brian Drucker, who's at the University of Oregon, is my hero, and he pioneered this therapy. So, we're not talking about CML, we're talking about CLL, and this is the most common type of adult leukemia. It's most prevalent as well, because patients can live with it for a period of time, and whether you're young or old, it's treated, unless you have real bad risk CLL with a genetic abnormality called the 17p, it's treated with chemoimmunotherapy, very kin to CML in the past. And if you have high risk 17p CLL, there was not a very good therapy until recently that we're going to talk about. And you would go on to a transplant, but your survival was expected to be 5 years or less with that. And in fact, when you get to the point of needing to be treated, virtually everybody with CLL with chemotherapy or chemoimmunotherapy, you would expect them to die in the absence of a transplant. And really, so the introduction of a drug called Ibrutinib has completely changed this disease. And I'm going to tell the story, and I'm going to go from lab to bedside, to lab to bedside. So say it may take a minute or two longer than I'm allowed it of the 80 minutes. So the story begins here with basic science and identifying that even though CLL doesn't have one gene target, it has many targets. There's a common biology, in high-risk patients where the immunoglobulin gene is unmutated, so it's a more immature B cell. And this was really hard to do in the 70s. And working in Dr. Griever's lab, there was a guy named Lou Stout who was at the NCI, and he wanted to collaborate with us, and we drove samples there, and we did a microarray. And microarray, at that time, was the RNA-seq, the CRISPR, the way that we fished them. And I like fishing because you can find things. Generally when I fish, I don't catch fish. I catch logs and other things and tires, and you can catch all kinds of interesting things. And fishing with microarray really caught something called ZAP70, which is not expected to be in this high-risk type of CLL, the IGVI mutated, but it sort of led us to a finding that B-cell receptor signaling might be important in CLL because ZAP70, a protein that's not supposed to be in CLL cells, is very similar to, it's in T cells, but it's very similar to a protein called SYK that drives BCR or B-cell receptor signaling. So the high-risk CLL had this increased ZAP70 and had BCR signaling, and so this is sort of telling us that BCR signaling was important. And then the microarray goes further, and this was not work done by us, but it was done by Adrian Wissner and colleagues, again at the NHLBI, where they did something at the NHLBI that we can't do at most academic places. They biopsied lymph nodes, they biopsied bone marrow, and then they collected blood in CLL patients, studied the tumors, and the significance of that is it's the hardest place to get rid of CLL is in the lymph nodes and the bone marrow. And what they showed was that in the area where it's most difficult to get rid of the CLL, the lymph nodes and the bone marrow, the signaling pathways that were most activated on the top was BCR signaling, or B-cell receptor signaling. And so this sort of led to, maybe in CLL, at least the places where it's hardest to get rid of and the part of the disease that ultimately takes over the patient, that BCR signaling was going to be important. And so we came up with, there are a variety of ways that you can target this, and I'm going to focus on Ibrutinib, and it sort of starts with, it starts with a story of being contacted as we were getting interested in this and getting contacted by a company that had an irreversible BTK inhibitor called Ibrutinib. And we were blessed to be able to do the lab work with this molecule as it moved in, as it moved into the clinic. And the lab work showed that this drug worked in a different way, and it worked. It worked to sort of drown the CLL, to remove the things from the microenvironment that keeps the leukemia cells alive. It also worked in dog models, and that's very important. So spontaneous dog models of lymphoma, which sort of tells us this was going to be a valuable drug. So the drug, as the preclinical work was being done, moved into phase 1 and was active in a variety of B-cell malignancies, and we moved it to the phase 2 study, where again patients treated with this drug, so laboratory to clinic, patients were treated with this drug. And 101 patients, were treated with relapsed and refractory disease, 31 who were untreated, who were elderly and not appropriate for chemotherapy. And particularly the relapsed and refractory patients were people that had really gone through all therapies. They were the high risk. You see 35%. Oops. That's my son probably calling. Dad, you have to give a talk. But what was important with this drug that was different was that the progression-free survival was very durable. So up 90% of patients responded, yes, 90%, and the remissions were very durable. This is these are out in months, and typically the remissions wouldn't be stable. And if you look at the untreated patients, essentially 96% of them at 3 years are still in remission. Now, there were genetics, so that 17p group didn't do as well in the treated setting. suggesting that some of them were going to relapse. But if you didn't have that, you didn't have the 17p marker, you did quite well. So we learned a lot from this initial phase, phase 1b/2 study. That led to phase 3 studies, the Resonate-1, which we led from here. It was published 2 years ago, showing that in patients with relapse disease, the best standard of care, Ibrutinib, beat the pants off it. It moved to the upfront setting, comparing this drug to a weak comparator, Quirembicil. We didn't participate in that study here because we didn't think that was a fair comparison. And I would say when you're doing clinical research, you want to be sure that your standard therapy is appropriate, and if it's not appropriate, then it's best. Those are trials we don't want to open, and we don't want to do. Drug companies like to do studies like that, but this did get the drug ultimately approved for patients, and we're now using this, and we're going to walk over. And my 140 patient in clinic is somebody that we're going to talk to about starting on Ibrutinib as a first-line therapy. So, thinking forward, how can we use our genomics to identify how we're going to treat patients? And really, in the untreated patients are doing very well. But in the treated patients, say both primary and secondary resistance, it's not that common. But in the 17p group, which the company showed, we saw more relapses, and so being here and having treated over 300 plus patients with this on trials, we looked at our experience to try to identify. I say we, Jennifer Woyak did this, looked at our experience and tried to identify features that predict for who's not going to do well. And again, this sort of shows the summary of the patients that have been treated here. And when we look at factors of discontinuation, first of all, you see in red, this is say with more than 3 years of follow-up, still more than half the patients are on drug, and most of these patients would be dead. So this is without this treatment. So that's incredibly rewarding to the team. But you see, the most common cause, for people going off, is progressive CLL and Richter's, which is a more aggressive form of CLL that sometimes patients develop late in the course of their disease. And then some patients went off for infection and other side effects or other reasons. And so we wanted to sort of look at, and again, using our clinical, and to go back to the lab and try to understand, what are the features of progression, and we see that 17p marker that the company identified. We don't see it, but we see something only we do at OSU, stimulated complex karyotype, really predicted for progression. Whereas for side effects, age was probably the most important thing. As you got older, you didn't do well, and we saw that at the bedside. Well, this sort of looks at the pattern of progression, and you see patients that progress with CLL, and again, this is 0 to 0.4, and we're looking over time. And early on, these patients that develop aggressive progression, Richter's, we see that. And then we see a subset of patients that go off for other effects. And so the timing, generally relapse with CLL is late. The important thing that we came to realize, though, is that patients that progressed either with Richter's, and that's what Transform says, or CLL progression, didn't do well. The survival was about 17 months if you progressed with CLL on Ibrutinib. The average survival was about 3 months if you progressed on Richter's. And so trying to figure this out, the best way to figure out if a kinase inhibitor or a resistant pathway is to look at samples before treatment and after treatment. And we really were very lucky in that when we did this with the drug binds to one site. And in at least the CLL patients that progress, 5 of the 6 had mutations by doing whole exome sequencing right where the drug binds. And in one patient, the mutation was right downstream. So right away, that validates the target, and it gives a common mechanism of resistance. So but that was 6 patients, and then everybody, and what often happens here is people, and this I can sort of editorialize, I guess, a little bit. Is when you're not on the East Coast or the West Coast, people even if they have less data, throw stones at what you're doing, and there's some people at meetings saying, well, this is poo-poo. It doesn't matter. This is not common, and so stick with your work, because as I said, we followed additional patients, and of the 34 patients when these data were last updated, we studied with a next generation sequencing assay that Gerard Lazansky and others developed in the laboratory. Say, are these mutations frequent in CLL? And of the 34 patients, we had 30 patients, and guess what? 87% of them had one or two of these mutations, the BTK or the PLC gamma 2 mutations. Whereas the Richters, we didn't see this, and there was a different. So it appeared there was a different biology in both. And so getting the patient samples when they relapsed, going back to the lab, we identified in CLL that these two mutations were very common. But Richter's transformation, we didn't see that. And so what's interesting though is that you just have to keep looking at data. And we had an hypothesis that a certain abnormality, that by doing fluorescence site to hybridization in the clinical lab was associated with this. And it turned out this 2P marker didn't, but with the patients that had 2P that developed Richter's, the other abnormality, had tetraploidy. And so for Richter's, we identified a biomarker, again, looking at clinical data that's very predictive of this. Well, say, how do we get back to the clinic with some of these findings? When patients progress on Ibrutinib, as I said, it's not a pretty sight. When they're fully progressing, they have very aggressive disease, and if you stop the drug and treat them with something else, their disease can sometimes explode. And after seeing this in a few patients, and this is one patient who's overtly sick, we had to hospitalize who had developed rapid adenopathy, a rising count, that we actually had to freeze his cells off, because he was having chest pain. We came to the conclusion we didn't want to see this, and so we had samples collected before, and you can see when we look back at bank samples from this patient before, approximately a year before, we could begin to see this mutation in BTK. And so we went back, and is this just one case? We went back and looked in 17 cases, and guess what? In 15 of the 17, actually half a year before they relapse, we could see these mutations present in the blood. And this is neat because it allows you to identify preemptively before patients get sick that they're going to progress and potentially do something. So, one moves on then to do. If you can see this, retrospectively in the lab, can this be applied prospectively? And we actually, with the Path Lab, moved this from the lab, our research lab, to the clinical lab to set up a CLIA-approved assay with Dan Jones in the molecular lab. Gerard transferred this from our group. And then studied 112 patients who were on Ibrutinib being treated here, and identified in that first year 16 who had these mutations. As we identified them we're in the early stage of relapse by standard criteria, and of the 12, 11 had findings suggesting that they were going to relapse. Their Ki-67 was going up, so the cells were proliferating. They had a rising B cell clone when you looked, or they had small lymph nodes that previously would have said, that were increasing, that previously would have said, well, maybe that's not progression. But ultimately, these clones continued rising, and so this, we can do this prospectively. So what are we doing now to apply this data? So lab, clinic, we're using this molecular relapse to target patients with new therapies while they're on Ibrutinib to try to get rid of these resistant clones. And we're also developing therapies, that go after patients who have clinical relapse. But really, we're trying to use our molecular relapse that we've identified with laboratory, testing. And the most important thing, though, is the best thing one can do is to prevent resistance. And as I said, using correlative data that came from the initial clinical trials, we've identified high-risk patients where we're either giving better drugs than Ibrutinib or the combinations. And the variety of members on the team that are working on this. And so what I'll leave is this is a story of a drug, Ibrutinib, that started preclinically, came into the clinic. We say identified it worked, identified there were some patients that progressed, went back to the laboratory to understand how resistance developed, went back to the clinic to figure out how frequent it was, went back to the lab to develop a biomarker, a CLIA-approved assay that we can talk to patients in clinic. We talk to patients. I've talked to 4 patients about their BTK study today. I'm going to go back and talk to someone after. And then now we're applying this biomarker to use it to change our therapy for patients who are in this high risk group. And this happens not for one individual, but it's a team. This is because you can't do translational work as a single entity. It's a team of clinicians, laboratory people. When I say, the clinical trial coordinators, and everybody working together. So with that, I'll finish, and I think I'm right on time. 20 seconds over. Sorry.